Hi, so this is chapter 36, care of patients with pituitary, thyroid, parathyroid, and adrenal disorders. So you do have some objectives for the lecture portion of this lesson, and that is to give examples of four major problems associated with hyposecretion of pituitary hormones, and to identify three nursing interventions appropriate for each problem. To identify nursing problem statements and appropriate interventions for patients with diabetes insipidus, to plan appropriate nursing evaluations and interventions for a patient who might experience complications of a thyroidectomy, to compare and contrast the symptoms of hypoparathyroidism with hyperparathyroidism, to identify 6 signs and symptoms of adrenocortical insufficiency or Addison's disease, and to summarize 4 major causes of Cushing syndrome. Clinical practice objectives for this chapter include to individualize care for a patient with a pituitary disorder by choosing patient problem statements appropriate to the patient, to select appropriate nursing interventions for a patient with adrenal insufficiency, to reinforce patient education for the patient with hypothyroidism, to plan postoperative evaluation and nursing care for a patient who has had a hypophysectomy, to evaluate the nursing care of a patient who has had a thyroidectomy, to identify nursing problem statements and appropriate interventions for a patient with diabetes insipidus, and to assist with the development of a teaching plan for the patient taking a corticosteroid. Okay, so those are your objectives for the chapter. Let's get into it. So, one thing that can go wrong with the endocrine system is a pituitary tumor. And when we think pituitary tumor, we have to think about all of those hormones that come from both the anterior and pituitary, or excuse me, anterior and posterior pituitary, and how many body tissues and body systems they may affect. So if we have an issue directly with the pituitary gland or the master gland, we have issues in at least one of those body systems, oftentimes two or more. So the cause of pituitary tumor, it's usually a growth of a benign pituitary adenoma. So not cancerous, but something that is causing growth and therefore overproduction oftentimes of hormone. Local symptom of a pituitary tumor is headache, right? As it continues to grow inside of the brain, there's only so much room. And so because of the excess tissue, your ICP is going to be off a little bit, causing headache. There also may be systematic symptoms or systemic symptoms like personality changes, weakness, fatigue, maybe some vague abdominal pain. We diagnose pituitary tumors by doing a history and physical, an MRI, or a CT with contrast. And we're able to visualize that pituitary tumor and collect the data about the patient's experience, clinical manifestations of the tumor. Treatment for pituitary tumor includes hormone therapies, so radiation, right? And then surgery. So the surgery that is done is oftentimes a hypophysectomy, which is a resection of the pituitary gland. So we're cutting out that tumor. So the usual approach for this type of surgery is transphenoidal. So we go through the nose and we go into the brain to resect that pituitary tumor, or we can go at the junction of the lips, upper lip and the gums, and we're going back. Following a hypophysectomy, we want to watch for things that could, be evident of trauma or damage to the pituitary gland. For example, your pituitary gland produces a hormone called antidiuretic hormone. It's incredibly important for fluid balance. And if you don't have enough antidiuretic hormone, that means you're peeing a lot because this is the no pee hormone, right? The slow pee hormone. And so if you're not having enough of that antidiuretic hormone being secreted, then you're going to be peeing quite a bit, and you can develop this condition known as diabetes insipidus. And diabetes insipidus is very, very dangerous because you become dehydrated, you have electrolyte imbalances, lots of really crazy cardiac arrhythmias can result. And we're really worried about the patient's well being if they develop diabetes insipidus. So we want to monitor output after this hypophysectomy procedure. We also want to monitor for drainage from the nose. We would expect to see, a little bit of bloody or mucousy drainage, right? That's pretty typical. We've gone through the nose to do a procedure. What we wouldn't want to see on that little mustache dressing that we sit underneath the nose is a clear fluid, because clear fluid or a very serious fluid would be indicative of cerebrospinal fluid leak, which would be concerning for us. We also don't want these patients to blow their nose or brush their teeth or do anything that might, like, you know, cleaning their nose out, removing dried bleeding, anything that would increase their pressure, okay, and potentially lead to a bleed. So here's that picture of the transsphenoidal surgical approach for the hypophysectomy, and we'll watch a quick video about this. I like that video. I think it does a nice job of summarizing kind of what we're doing during that transsphenoidal surgical care and what the patients have questions about. Okay. Post-operative management, we want that patient in the semi-Fowler position. That's good for cranial pressure, right? We also want to know any changes in their vision, mental status, level of consciousness, or strength. We want to observe for those signs and symptoms of diabetes insipidus. And we also want to leave that nasal packing in place and apply that mustache dressing if it's not in place already. We don't want to remove that unless the physician has given us an order to. Then we want to teach the patient about the things not to do. So don't blow your nose, don't brush your teeth, etc. Hyperfunction of the pituitary gland. So this is any time that the pituitary gland is overproducing hormones. And the most common cause of this is actually that pituitary adenoma. It causes an increase in the release of hormones. Whenever you have too much of a hormone, the first thing you should consider is that you have too big of a gland. So too big often equals too much. Stress and pregnancy may also cause increased hormone release. We look for signs and symptoms. Physical ones are really obviously manifested, things like unusual size or growth. So, gigantism in children, acromegaly in adults may be indicative of hyperfunction of the pituitary gland, and they're both hyperfunction disorders. We're producing too much growth hormone, and therefore we have an unusually large amount of growth. How do we treat hyperfunction? Well, we have to remove remove the cause. So either reduce stress or deliver the pregnancy or resect or remove the pituitary adenoma. Here's a good image of acromegaly. This is from your book. So you see this child here. She doesn't appear completely unusual. She may be a little tall for her age, a little broad. But then you can see as she ages, this woman actually develops quite typical features of acromegaly: large hands, unusually large stature, a very pronounced jaw, broad shoulders, overgrowth of bony tissue in the face. And then we have a really great video here of Froggy and his personal experience with acromegaly I'd like to share with you.
Being on the radio for the past 10 years has been a dream for me. Working as a host for one of the most widely listened to syndicated morning shows in the US allows me to touch a lot of people. I love that I'm able to make people smile and laugh each and every single morning. I'm a husband and a father of two, and I live every day with a rare hormonal disorder called acromegaly, which is caused by a non-cancerous tumor on the pituitary gland. Having acromegaly changed me, both inside and out. Before being diagnosed and treated, I was tired all the time. I'd get really bad headaches and I'd sweat profusely. My appearance also changed drastically. My hands became larger, so large in fact that I had to resize my wedding ring 4 times. My feet grew from a size 10 to a 14. My jaw grew so large that eating and speaking became difficult. Not an easy thing for somebody who makes their living by talking. I literally felt like I was growing out of my body and became depressed all at the same time. I remember one of my friends, who I hadn't seen in a while, came up to me looking shocked and said, "Wow, Froggy, you look really different." I knew something was wrong, but I wasn't ready to face it. Then one day my mom was watching Jeopardy and saw a clue that read, "A disease that causes a pronounced lower jaw and a protruding forehead." The answer was acromegaly. She called me right away and told me I needed to see a doctor. I immediately went online and did research to find out what I needed to know and scheduled an appointment with my primary care doctor. Getting the diagnosis was not simple. When I told my primary care doctor that I suspected I had acromegaly, she told me she didn't think so. I respectfully disagreed and insisted that she send me for more testing. When the results came back, there was no question. My IGF-1 levels, one of the hormones that become elevated with acromegaly, were 6 times higher than normal. My GH levels, the other hormone affected in acromegaly, were also very high. I asked to be sent for a pituitary MRI. The scan showed I had a large tumor growing on my pituitary gland. Once we found the tumor, my doctor sent me to an endocrinologist to confirm my diagnosis. After reviewing the results of the test, my endocrinologist told me I had acromegaly and needed to have pituitary surgery to remove the tumor. I'll admit I was scared when I received my diagnosis, but I was also relieved because I finally knew what was causing my symptoms and I could now move forward with treatment. By the day of my surgery, my IGF-1 levels had shot up to 9 times higher than normal, an indication that my tumor had been growing really quickly. A week later, I learned that the excess hormones in my body had caused a buildup of polyps in my colon, and I needed to have a portion of that removed as well. The following year, I decided to have jaw surgery to repair my jaw. I'm currently controlling my acromegaly by taking monthly injections. I also work with my endocrinologist to monitor both my IGF-1 and GH levels on a regular basis to help keep my acromegaly under control. Living with acromegaly has been an emotional roller coaster. I found it really helpful to talk through these feelings with my wife, family members, and a therapist who specializes in serious medical conditions. I'll admit though, with all the changes that took place in my body, I still feel self-conscious sometimes about the way that I look, and I'm not crazy about taking pictures. I try to stay positive though, and focus on what's important, like enjoying life and maintaining my health. I can't say it's always an easy road, but I know that if I don't take steps to ensure that my IGF-1 and GH levels are controlled, I could face other serious health consequences, like heart disease or diabetes. I'm determined not to be held back by this disease. That's why I go for routine checkups with my endocrinologist. I am diligent about monitoring my hormone levels to ensure that both my GH and IGF-1 levels are where they should be. My wife also helps me stay on track by regularly reminding me to take my medication so that I stay in control of my levels. I've been very fortunate that I was able to address my disease so quickly following my diagnosis. Before surgery, I weighed 205 pounds. I'm now back to 160. My shoe size has gone down to a size 11 and a half, and I even wear my original wedding ring that I got the day I got married. I feel very blessed that I can share my story about living with acromegaly with others. I encourage others to educate themselves as much as possible. I'm not defined by acromegaly because I took control. Anyone can take control like I did. Don't let acromegaly define you. Visit acromegalyinfo.com in the US or aboutacromegaly.com outside the US to learn more.
Okay, so let's jump back into the lecture now that you know a little bit more about acromegaly. So, hypofunction of the pituitary gland is when the pituitary gland doesn't produce enough hormone. So, hyperfunction is too much, hypofunction is not enough. Ironically or counterintuitively, the most common cause for this is also tumor. This is a tumor that's actually caused damage to the pituitary gland. Um, Non-secreting large tumor. Autoimmune disorders, infections, and destruction of the pituitary gland due to trauma or other brain surgery may also cause hypofunction. Sheehan syndrome is a condition linked to postpartum hemorrhage. So you think postpartum hemorrhage, a mom has lost quite a bit of blood. When she loses that blood, certain tissues become ischemic. Ischemic means they don't get enough oxygen or nutrients from the blood, and they're not getting enough blood flow. And because of that, that ischemia causes death of the tissue. And so when we are ischemic in the pituitary gland tissue begins to die, and then it's not going to function. A decrease in growth hormone and gonadotropins can also result in hypofunction of the pituitary gland. What do we see? Well, if the patient has a tumor, we still see headaches, visual changes, anosmia or the loss of smell, potentially seizures. And if there's another issue or another hormone involved, we may see other symptoms that are really dependent upon that hormone. We diagnose this kind of the same way. We do a history and physical. We may do an MRI and CT to try to visualize a tumor. We also test for the levels of pituitary hormones because if they're low, then we have hypofunction. We need to teach that it's very important that we replace these hormones over the lifetime. So you can't just stop taking the hormone replacements. We may do surgery or radiation if there's a tumor, and there's lots of patient teaching involved with hypofunction of the pituitary gland, including explanation of the disease process, treatment of all the various sequelae from the hypofunction of the pituitary gland, and also just that continual education about hormone replacement. Let's dig into the first condition of an issue in the pituitary gland, and that is diabetes insipidus. Diabetes insipidus, we talked about this a little bit earlier in the presentation. Diabetes insipidus is often caused by trauma during a resection, a hypophysectomy of the pituitary gland. So diabetes insipidus is a disease in which the secretion of or the response to the pituitary hormone vasopressin is impaired. So there's large amounts of dilute urine produced, causing dehydration and insatiable thirst. So vasopressin is antidiuretic hormone. We also can give desmopressin, which is our synthetic version of that as well, or DDAVP. So there are different types of diabetes insipidus. We'll briefly go over those. There's central, which are associated with your brain tumors, head injury, neurosurgery, or central nervous system infection. There's nephrogenic diabetes insipidus, which is actually caused by drug therapy, lithium specifically, or kidney disease, chronic kidney disease. And then there's dyspogenic diabetes insipidus, and this is where a person is just drinking a tremendous amount of water. Maybe they have schizophrenia, maybe they have dementia, or maybe they have some kind of cognitive concern, and they're just taking in copious amounts of water and therefore producing copious amounts of dilute urine. It has nothing to do with the hormone vasopressin, but it is mimicking that diabetes insipidus. So what do we see when a person has diabetes insipidus? Well, they're going to have a lot of urine, right? So diuresis. They're also going to be very thirsty. They may also be weak or fatigued, and they might pee at night. It's called nocturia or urination at night. They'll have deficient fluid volume because they won't be able to build a good blood supply due to peeing out all of their fluid. They also may exhibit signs of shock, specifically, low volume shock, and they may have central nervous system manifestations, so neuro signs and symptoms. Diabetes insipidus has no effect on blood glucose levels. So this is not related to diabetes mellitus. They're completely different. A trick for remembering how diabetes insipidus presents for me is I say it a little bit differently. I say diabetes insipidus. And it helps me remember that they are sipping and peeing a lot. Diabetes insipidus. Okay, sipping and peeing. Diagnosis. We're going to do a history and physical exam. We're going to look at their urine. This is going to tell us a lot. It's going to tell us that they have a low osmolality. So, as far as the concentration of the urine, it's going to be extremely diluted, not concentrated. And they're going to have a gravity that reflects a large volume of urine being produced. We're going to put them through what's called a water deprivation test as well. During a water deprivation test, we want the client to be admitted to the hospital. They're going to get tele leads placed so that we can closely monitor their heart. They're either going to get a Foley or they're going to be on strict I&Os, and they're going to have no access to water. Super important, we also get an IV so that we can respond appropriately to any emergencies or once we've determined that this person does in fact have diabetes insipidus. And so we're going to do hourly ISNOs, hourly monitoring of their fluid balance as we keep them from drinking. So ideally, we would see a decrease in urine, right? You're not drinking, you shouldn't be peeing. But if you have diabetes insipidus, you're going to continue to deplete your volume. Okay. You're going to pull that fluid from somewhere because you're going to be unable to reabsorb that water in your nephron, right? In your renal tubules. And so we want to see, to diagnose diabetes insipidus, we want to see large amounts of dilute urine being produced despite limiting PO intake of fluid or IV intake. Obviously, they're not going to be getting any fluid. Once we can confirm that, we also need to be doing weights to see how much weight we've lost. Once we've confirmed that, or the person has developed a cardiac arrhythmia, or the person has lost too much weight or too much fluid, we're going to need to intervene. So we need to give the patient fluids to rehydrate them intravascularly. And then we want to give them a medication called desmopressin or vasopressin. And we'll do injections of this medication. And what that's going to do is it's going to uh, be like exogenous, right? Hormone to replace the ADH that their body is not producing on its own, or the vasopressin that their body is not producing on its own. And hopefully, the response to that in a diabetic insipidus patient is that they would stop producing the copious amounts of dilute urine. Okay, treatment and nursing management. We want to replace the fluid and electrolytes. We want to use a hypertonic saline. We want to titrate it to match their urinary outputs. We're going to put them on hormone therapy, and during the test, of course, we're going to be giving them those sub-Q injections. We also need to detect this early so we can maintain their fluid and electrolyte balance and provide lots of education. Baseline vital signs are super important. Baseline weight are super important. We got to monitor those. And then as we talked about, that strict hourly I&O is essential. Now, the opposite of diabetes insipidus is a condition known as syndrome of inappropriate antidiuretic hormone, lovingly known as SIADH. And in this particular disease process, we have excessive amounts of ADH being produced, which results in tons of fluid overload, fluid retention. These patients become very confused because their brain starts to swell. They may have seizures. They may lose consciousness. They'll gain a tremendous amount of weight because they have all this fluid on board and are unable to pee it out. And they will be super, super swollen, right? They may become hyponatremic, right? Because there's so much fluid on board, it is diluting the amount of sodium in circulation. They may develop muscle cramps, be extremely weak, and they're going to have oliguria or a low amount of urine output. So here's a good visual for the pathophysiology of SIADH. Increased levels of ADH result in the renal tubule not being able, being extremely permeable to water, and therefore we have this increased water reabsorption. And this does two things. It decreases the amount of urine, which creates this hyperosmolar urine or extremely concentrated urine, and increased urine sodium. And another thing that it will do is increase the blood volume, which is going to increase the serum osmolality and cause dilutional hyponatremia. Both of these things in coordination with, with this increased urine sodium, we're going to activate out a suppression of aldosterone and result in dilutional hyponatremia as well. And when we have dilutional hyponatremia, this increased serum osmolality, this extreme hyperosmolar urine with extreme concentration, we're going to develop anorexia, nausea, vomiting, irritability, confusion, disorientation, and eventually seizures and potentially death. So it's very serious. We'll want to do those urine and serum osmolality tests. We'll also want to look at the BUN, the creatinine clearance, the hemoglobin, the hematocrit. And then we want to correct the underlying cause. These people are going to have to go on extreme fluid restriction because they have too much on board already. So 500 to 1,000 milliliters per day maximum. We're going to give them sodium chloride, diuretics to pull the fluid off, and a medication known as demeclocycline. I'll get it out. Another medication we're going to give them that's super important is tolvaptan. Another name for this is Samska. And what this is going to do is it's going to increase the amount of sodium in their blood. It's going to treat that hyponatremia. It works very quickly within 8 hours, and it's given as an IV infusion. It blocks the action of antidiuretic hormone. Be very careful with this medication, though, because there is a danger of overcorrection in which the sodium levels would raise too high. So we need to closely monitor the sodium levels. Okay, so those are some of our pituitary disorders. We talked about acromegaly. We didn't talk about what happens when the pituitary gland underproduces, but that is called pituitary dwarfism. And it's just the absolute opposite. We talked a little bit about that antidiuretic hormone, so SIADH and diabetes insipidus. Now we're going to move on to the thyroid. So one of the conditions that can result in the thyroid is called goiter. And this is where you have a greatly enlarged thyroid gland due to not having enough iodine or a lack of thyroid hormone. You develop an enlargement in the front of the neck, and you treat it with elemental iodine or thyroid hormone or levothyroxine. We want to monitor this patient for tachycardia, palpitations, nervousness, headaches, or fatigue, which may indicate we've given the patient too much of the thyroid hormone. And then whenever we give iodine, it can stain the teeth. So we want to give it really well diluted and through a straw. Have them brush their teeth afterwards too, so it doesn't stain. Okay, we're going to watch a quick video about thyroid goiter.
If you've had problems with a goiter, you know it can be a pain in the neck. But do you know what's behind the bulging bump?
Goiter is a general definition of an enlarged gland. And it has a lot of a lot of different causes.
The most common cause worldwide is an iodine deficiency. The thyroid concentrates iodine from the body to produce its hormone. In the absence of iodine, the body attempts to compensate. It's still an issue in undeveloped countries. In this country, goiter cases dropped drastically in the 1920s once iodine was infused in table salt. The more common cause of goiter in the U.S. is autoimmune thyroiditis, where the body attacks itself.
The general term that applied to it is Hashimoto thyroiditis. The gland burns itself out and essentially stops functioning.
Graves' disease may also produce a goiter.
Graves' disease is a hyperactive or excessively active thyroid. It becomes enlarged, swollen, and very uncomfortable for patients, and is treated medically very, very easily most of the time with either medication or radioactive iodine.
If a goiter gets so large that it constricts the airway, your doctor may recommend removal. In itself, the goiter is generally harmless.
And an enlarged gland itself is of no consequences unless, one, you have symptoms of breathing difficulties, swallowing problems, or pressure sensation, or if it's quickly enlarging to suggest that you may have something else going on, such as a tumor growing.
If you or your doctor detects a goiter, it's important to determine the cause and then respond appropriately. For Lee Memorial Health System, I'm Amy Osher.
I love that video because I think it does a great job of explaining how important iodine is and that we get most of our iodine in the US from our iodized salt. So that was such a great video. Preventing goiter. So what can we do? Well, we know that goiter is an overgrowth of the thyroid that may be prevented by sufficient intake of iodine. And iodine is available in foods that are grown near the ocean, seafoods, etc. However, iodized salt is the major source for most people. What do we do to figure out if we've got an issue with the thyroid, specifically one that's causing goiter? Well, we can do a thyroid panel. It's super important when we do a thyroid panel that we follow all of the rules and procedures for the thyroid panel test, including not to take our aspirin before the test, because that can actually throw off the results. So a thyroid panel consists of T3, T4, and thyrocalcitonin. And also TSH, and will give us a good indicator of how the thyroid is doing as far as its function. We also are going to check parathyroid function. Remember, parathyroid glands are the 4 to 6 glands that hide behind the thyroid, and they're about pea-sized. And we're going to check serum calcium and phosphate levels to detect how well the parathyroid is working. So if the parathyroid was low if the serum calcium was low, for example, then we'd be concerned about there not being enough parathyroid function. And if it was high, we'd be concerned about it being hyperactive. We also would want to check for adrenal gland function, do things like electrolyte panels, check glucose levels, hormone levels, and then a 12-lead EKG. There's a really good image for hyper versus hypothyroidism. We're going to kind of start to move into these. Hyperthyroidism is when the thyroid works too well. It does its job too much. So we think high and hot. So they have a high heart rate, high respiratory rate, high temperature. They have high anxiety, right? They have a high metabolism, and they're hot. They're temperature sensitive to warmth. So lots and lots of things that we see with that. We see lots of weight loss. We see bulging of the eyes or exophthalmos. Graves is the autoimmune condition associated with hyperthyroidism. And this is when we gain high. So it even gets higher than baseline hyperthyroidism. So extreme tachycardia, extreme fluctuation in temperature, extreme metabolism and weight loss, etc. Hypothyroidism, of course, is going to be the opposite, low and slow. So think low temperature. They're going to be very cold and cold sensitive, low blood pressure, low heart rate, low peristalsis, which means that they're going to become constipated, low bone mass because of their decreased thyrocalcitonin. Also, they're going to be very depressed, slow metabolism, right? Hyperthyroidism. So The primary cause of, the primary hyperthyroidism is caused by either Graves' disease, which is your autoimmune disease of the thyroid itself, or toxic goiter, which is where you have that overgrowth of tissue that's producing hormone. Secondary hyperthyroidism can be caused by something like a pituitary tumor or a outside cause of the thyroid working too well. Maybe you're taking too much synthetic thyroid hormone like levothyroxine or Synthroid. Maybe you're have some other condition going on in the body that's causing you to be in a hyperthyroid state. Earliest symptoms for hyperthyroidism include weight loss and nervousness. Later symptoms may include weakness, insomnia, tremulousness, agitation, irritability, tachycardia, palpitations, exertional dyspnea, ankle edema, difficulty concentrating, diarrhea, increased thirst and urination, decreased libido, and scanty menstruation. Here's the exophthalmos that we were kind of talking about. These are your pug eyes that develop with Graves' disease, the autoimmune condition of hyperthyroidism. And let's watch a short video about Graves' disease.
Graves' disease is an autoimmune disorder affecting millions of Americans, mostly women starting in their 20s and 30s. It's caused by the thyroid overproducing hormones that control metabolism.
The most common thing that people know about Graves' disease is you will start losing weight regardless of your appetite. The other thing you have is fast heartbeat.
The overactive thyroid can also cause heat sensitivity, nervousness, frequent bowel movements, trouble sleeping, and trouble getting pregnant. While noticeable, these symptoms may not add up quickly, but there are telltale signs written across a patient's face.
Their eyeball will protrude in the front of them, and it's called orbatopathy. So they have special eye look. And also it can affect your skin. You can have non-pitting edema, like swelling of your limb.
Graves' disease is the only form of hyperthyroidism that affects the eyes in this way. The bulging is the result of inflammation and swelling of tissue behind the eyes. It can also cause double vision, which is why doctors keep a close eye on its progression.
Problems with irritation, redness. If it's severe, they cannot even close their eyes while they are sleeping. We have some measurement to the eye, so each visit we see and look if it's advancing or not.
Drug therapy and thyroid surgery are both treatments for Graves. Eye issues may require additional treatment or surgery, but in people searching for a cause to their worrisome woes, their eyes may give them away. For Lee Memorial Health System, I'm Amy Osher.
Okay, so the look of Graves' disease. Let's hop back into the PowerPoint. Hyperthyroidism is diagnosed by its clinical manifestations or the signs and symptoms associated with it. The heart rate while sleeping or at rest, which gives us a good indicator of that metabolic rate. Electrocardiography, CT, or MRI to show us how the heart is beating and what rhythm it's in, and also if there's an overgrowth or tumor on the thyroid. How do we treat it? We can give a medication that's radioactive iodine. We can also give antithyroid drugs like Tapazole or Methimazole. It is commonly used as an antithyroid drug for people with hyperthyroidism. We can also give patients mild sedatives and beta-adrenergic blocking agents, both to decrease their heart rate and blood pressure, but also to decrease their anxiety, restlessness, and agitation. Okay, here's a question for you guys. The nurse provides patient instructions regarding taking iodine preparations. It is important for the nurse to include what? Select all that apply. Dilute the preparations well. Use a straw to prevent staining of your teeth. Watch for easy bruising. Report severe epigastric pain, or anticipate a metallic taste. Which of these things should we include in our teaching about iodine? And the correct answer is 1, 2, 4, and 5. We want them to dilute it, right? To use a straw so they don't stain their teeth, to report any severe epigastric pain and also to anticipate a metallic taste of the iodine. Here's a really good visual for the regulation of thyroid hormone secretion. Our hypothalamus releases the thyrotropin releasing hormone, and the anterior pituitary receives that and produces TSH or thyroid stimulating hormone. The thyroid gland receives the thyroid stimulating hormone and produces T3 and T4. And then your T3 and T4 are the thyroid hormones that produce metabolic effects. And so, whenever you have an increased amount of T3 and T4, the anterior pituitary knows that it doesn't need to produce more TSH, so it will reduce its production. And whenever you have great metabolic effects, that inhibits the release of the thyrotropin releasing hormone from the hypothalamus. Let's talk about thyroid crisis. This is also called thyroid storm and thyrotoxicosis. Thyroid crisis is caused by the sudden increase in the output of thyroxine due to a manipulation of the thyroid as it's being removed during the thyroidectomy. Another cause of thyroid storm may be improper reduction of the thyroid before surgery. In patients that have hyperthyroidism, it can also be triggered by other factors unrelated to surgery. For example, an overdose of levothyroxine, pregnancy, infection, all of those things can cause a thyroid storm. The temperature during a thyroid storm raises to 106 degrees, so it's incompatible with life. The pulse increases up to 200 beats per minute, once again, incompatible with life. The respirations become rapid and the patient starts to become extremely apprehensive and restless. And unless that condition is relieved, the patient quickly passes from delirium into coma into death due to heart failure. So, what do you do when you suspect your patient is having a thyroid storm? So, first of all, if you start to see anxiety or restlessness prior to a thyroid surgery, you may be concerned that the patient didn't take their medication to inhibit the thyroid like they were supposed to. Um, let's see that you recognize that your patient is going through a thyroid storm after surgery. You can reduce the patient's temperature, and then you can get an order for cardiac drugs to slow the heart rate. This is an emergency, so the first thing you would do is tell your doctor and charge nurse. Sedatives can also be given, like barbiturate, in order to reduce restlessness and anxiety. Here is another NCLEX practice question for you. A patient receives large doses of radioactive iodine or iodine 131 for hyperthyroidism. Appropriate nursing interventions include what? Select all that apply. Monitor the vital signs, restrict fluids, encourage eating high-calorie foods, properly handle contaminated materials, or encourage physical activity. Correct answer is to monitor those vital signs and make sure you're handling contaminated materials appropriately because the materials themselves can become radioactive even though the patient isn't radioactive. Let's talk about hypothyroidism. So here's the opposite, not enough thyroid hormone. It can be due to decreased TSH. It can be due to reduced releasing hormone from the hypothalamus. It could be due to a failure in the thyroid gland itself and therefore reduced T3 and T4 organically. So it can be caused by inflammation of the thyroid or treatment of hyperthyroidism. If we give too much of the anti-hyperthyroid, then we can create hypothyroidism. Or the person can be born with it. This is called congenital hypothyroidism or cretinism. Underactivity due to a pituitary or hypothalamus dysfunction can happen as well. Children have delayed physical and mental growth when they go through hypothyroidism. Adults have a decrease in appetite, but an increase in weight because they have a slow metabolic rate. They may become lethargic, sleepy, take extra naps during the day, or have slurred speech. How do we diagnose hypothyroidism? Well, first of all, we look for those signs and symptoms. And then we do a thyroid panel. We look at the serum levels of thyroid hormones and TSH. We want to replace the thyroid hormone with a medication called levothyroxine or Synthroid, and that usually works very well with a very quick cessation of symptoms. Thyroiditis. Thyroiditis is inflammation of the thyroid. So there are three types of thyroiditis. There's acute thyroiditis, which is related to a infection or trauma. There's a subacute, which is also related to some kind of underlying situation. There's chronic thyroiditis, and there's autoimmune thyroiditis, which is more of a chronic thyroiditis. And this is known as Hashimoto's. Hashimoto's, we see that painless enlargement of the thyroid gland and those symptoms of hypothyroidism. This is hyper, but most of the time we see hypo with the Hashimoto's, right? Initially, we may see that bump up, but then we see a lower level. So thyroid levels and a needle biopsy will help diagnose thyroiditis. For acute, we treat with antibiotics because we said it was usually infection. And with chronic, we replace the thyroid hormone. You may have to do surgery to remove part of the thyroid gland, but the goal of therapy and overall is to decrease the size of the thyroid and prevent hypothyroidism. Nursing management will focus on the patient teaching and providing for comfort for that patient. Thyroid cancer. So the most common form of thyroid cancer is actually papillary carcinoma. 80% of thyroid cancers are that papillary carcinoma, and it occurs mostly in younger women. Other thyroid cancers include follicular carcinomas, medullary thyroid carcinomas, and anaplastic carcinomas. We see a thyroid nodule or a bump or a lump. We might have some voice changes, trouble breathing or swallowing, fatigue, depression, or weight changes. And what do? We're going to take it out. We also may give radioactive iodine or multiple other drug therapies like chemos, etc., especially if the patient is not a candidate for a thyroidectomy. Most are given to control tumor growth, not to cure the condition, just to control it until they're able to have a thyroidectomy or give them a better quality of life. Hypoparathyroidism. So hypoparathyroidism is something we worry about when we remove the thyroid, because on the back side of the thyroid are those 4 to 6 small pea-like glands, those parathyroid glands. And when we remove the thyroid, we can either remove some of the parathyroids or damage them in the process. So it's most commonly caused by an atrophy or traumatic injury to the parathyroid glands. Decreased parathyroid hormone will result in decreased serum calcium. So we'll have hypocalcemia with hypoparathyroidism. Accidental removal or destruction of parathyroid tissue during a thyroidectomy, radiation of the thyroid or parathyroid, neck trauma, or some kind of idiopathic cause can result in atrophy of the glands as well. So because hypoparathyroidism results in hypocalcemia, we have mild tingling, numbness, muscle cramps, mental changes such as irritability, right? We're looking for low calcium signs and symptoms. We also may see Schwastek sign, which is where we tap that facial nerve and we see the twitch, right? Or Trousseau sign, which is where we inflate the blood pressure cuff and we watch to see if the hand pronates and contracts, right? If we see that sign, it's a positive Trousseau sign. We also may see tetany. Signs of tetany are those changes in sensation, ability to move. So they may have some paralysis. They may also have some seizure-like activity, right? Convulsions, cardiac dysrhythmias, and spasms of the larynx may also occur. So here's a really great video that demonstrates Schwastek and Trousseau signs.
Grammarly is such a lifesaver for all students. Honestly, if you don't have it, where have you been? It's basically a digital writing system.
Hi there. Welcome to Hippo Shorts. In this segment, we're going to talk about Schwastek sign and Trousseau sign. So these are the classic physical exam findings we see in patients with hypocalcemia. So let's take a look at Schwastek sign. What we see here is twitching of the facial muscles in response to tapping over the facial nerve area. Unfortunately, this test is neither sensitive nor specific. It's absent in about 30% of patients with hypocalcemia and present in 10% of patients with normal levels of calcium. Let's take a look, though, at this next test. This is Trousseau sign. What we see here is the development of carpopedal spasm that results from ischemia. One way we can induce that ischemia is application of a blood pressure cuff. So that gets inflated over the arm, and then we see this gradual flexion of the fingers and thumb, and then we also see flexion at the wrist, and then some degree of pronation. So this test is actually more sensitive and specific. It's present in 94% of the patients with hypocalcemia and only occurs in about 1% of patients with normal calcium. That wraps it up for this section of Hippo Shorts. For more information on this or other topics, come on down to hippoeducation.com. We'll see you next time.
Okay, so that was a good visual of Shostak and Trousseau sign. Let's hop back into hypoparathyroidism. How do we treat it? Well, if it's acute hypoparathyroidism, we're going to give them IV calcium gluconate to raise their serum calcium level and also vitamin D in order to synthesize the calcium. We may also give oral or parenteral calcium salts. For chronic hypoparathyroidism, they're going to need to go on a parathormone replacement therapy and also receive large amounts of vitamin D with that calcium replacement and oral administration of calcium salts. Nursing care is going to revolve around making sure the electrolytes are replaced and balanced and teaching the patient how to care for themselves on an ongoing basis. It's important to remind the patient that therapy for hypoparathyroidism is going to be lifelong and they should wear a medical alert bracelet. Hyperparathyroidism is the opposite. This is where we have excessive parathyroid hormone. And usually when we have too much hormone, it's because our gland has become too big. So a benign enlargement of the parathyroid glands, usually an adenoma or hyperplasia of two or more of the glands, is most often the main cause. Signs and symptoms include dehydration, confusion, lethargy, arrhythmias, anorexia, nausea, vomiting, weight loss, constipation, thirst, frequent urination, and hypertension. Remember, we're going to see hypercalcemia with this condition. We will diagnose with the serum calcium and phosphate level, a serum parathyroid hormone level, and a serum albumin level. How do we treat it? Well, we resect the tumor. So surgical removal of the adenoma is generally our first line for a primary treatment method. Secondarily, we will give vitamin D supplements in order to encourage the synthesizing of the calcium. Nursing management for patients on diuretic therapy includes accurate measuring of INO every 2 to 4 hours, daily weights, monitoring of the serum electrolytes, ongoing assessment for electrolyte imbalance, and appropriate nursing interventions. So what causes hyperparathyroidism besides a tumor? So we know parathyroid tumor, either benign or malignant, can cause it, but there's also potential for congenital enlargement or just enlargement that you're born with. Neck trauma or irradiation can cause hyperparathyroidism as well. Having a vitamin D deficiency, chronic renal failure with hypocalcemia, and lung, kidney, or gastrointestinal tract cancers can also cause hyperparathyroidism. Pheochromocytoma. So this is a kidney adrenal gland condition. So we're moving away from the thyroid. We've talked pituitary, we've talked thyroid, we've talked parathyroids. Now we're talking about adrenal gland disorders. So pheochromocytoma is a rare tumor of the adrenal medulla that secretes catecholamines. So catecholamines are your epinephrine and norepinephrine. Usually these are benign, but they do show malignancy in about 10% of cases. What do we see? We see tachycardia and severe hypertension. We also may see profuse diaphoresis, severe headache, palpitations, nausea, weakness, and pallor. What do we do? Well, we resect it. It is a surgical removal in order to treat pheochromocytoma. The patient may be in a hypertensive crisis and require close monitoring of those vital signs and administration of IV antihypertensives. Adrenal cortical insufficiency. So this is the cortex of the adrenal glands is not producing enough, specifically cortisol. It causes a condition known as Addison's disease. You can add some cortisol to a person with Addison's disease. Primary insufficiency of corticosteroids results in can be caused by idiopathic atrophy, autoimmune disease, inflammation, infection, or a non-secreting tumor of the adrenal cortex. Secondary insufficiency, which means that it's caused by something outside of the gland itself, may result from pituitary gland failure to secrete ACTH because the gland is under functioning or was surgically removed during a hypophysectomy or after an abrupt withdrawal of steroids. Early stages of Addison's disease, symptoms can be very vague, but in the later stages, we see fluid and electrolyte imbalances, hypoglycemia, we see issues with low blood sugar, bronzing of the skin. Blood cortisol and aldosterone levels need to be evaluated because mineralocorticoids are affected as well. So aldosterone is affected as well. And an ACTH stimulation test may be ordered. We also are going to do a CT and an MRI to verify that there is not a tumor, or if there is a tumor, that we have resected the entire mass. Prednisone is going to be given to replace the glucocorticoid, specifically your cortisol. And fludrocortisone is a synthetic adrenal corticoid steroid to replace the mineralocorticoid aldosterone. Replacement therapy to provide the missing hormones usually brings about a rapid recovery, but the patient must continue to take the hormones as lifelong therapy. It's important that we provide intensive care and support during Addisonian crisis and prevent problems related to extreme fatigue and orthostatic hypotension. We need to help to alleviate the GI problems that are associated with Addison's disease and provide thorough patient teaching and support. Here's a really nice visual for Addison's disease. What do we see? Well, we see that bronze pigmentation in the skin. We see hypocalcemia, and therefore that profound fatigue. We also see postural hypertension, so low blood pressure. We see weight loss, weakness, GI disturbances, and changes in distribution of body hair. During an adrenal crisis, the patient becomes extremely dehydrated. Their blood pressure drops pretty substantially to almost complete vascular collapse. Their kidneys begin to shut down. Their serum sodium is very low and their serum potassium is very high because they don't have aldosterone working in the renal tubules. Excessive adrenocortical hormone or adrenocortical hormone production is called Cushing's syndrome. These people have lots of Cushing and they don't need any extra cortisol or aldosterone. Causes of Cushing syndrome include an excessive secretion of ACTH by the pituitary gland, which may be resulting from a faulty release of corticotropin releasing factor from the hypothalamus. A secreting tumor of the adrenal cortex can also cause Cushing syndrome. And then there are other tumors that may be like in the lungs, for example, with lung cancer, that are outside of the pituitary gland, outside of the adrenal glands, that can produce ACTH, which triggers the adrenal glands to produce those glucocorticoids. So iatrogenic Cushing syndrome can also be used can be produced by the patient being on a long-term steroid therapy. Signs and symptoms of Cushing's include the development of a buffalo hump and moon face. So you start to see like supraclavicular fat padding and fat pocketing around the face and neck region as well. They also might have an enlarged abdomen with really thin arms and thin legs, bruising even after they've had a minor trauma, impotence or amenorrhea, hypertension or high blood pressure, and weakness. We diagnose this with a plasma cortisol level. We also could do a 24-hour urine test to look for the amount of sodium in the urine and also potassium in the urine. And then we'll do a dexamethasone suppression test to confirm Cushing syndrome. Here's a good visual for Cushing syndrome. This is what we see. We see thinning of the hair, acne, reddened cheeks, a moon face or round face, that buffalo hump, and that supraclavicular fat pad. These patients are typically obese with high blood sugar. They have those thin extremities with muscle atrophy, thin skin and subcutaneous tissue, slow wound healing, and increased tendency to bruise. They may have stretch marks in their abdomen, and they may not have periods that are regular. Treat this with microsurgery on the pituitary gland if there's a tumor there. We may also have to do an adrenalectomy with replacement of glucocorticoids, or we have to take out the adrenal glands and then replace the glucocorticoids that we need. We also may give medications to block the effects of the cortisol or radiation to treat a cancer. Nursing management is primarily concerned with helping the patients cope with the many systemic problems that are caused by the disorder, and then psychosocial support for the physical changes that occur as well. Here's another visual for Cushing's. It also includes the hyperglycemia, CNS irritability, and personality changes, edema due to the sodium and fluid retention. In males, they develop breast tissue or gynecomastia. We see increased acid in the tummy, and so the patients typically have GI issues. Thin skin, purple striae, bruises and petechiae, and also osteoporosis are related to Cushing syndrome. Here's a good critical thinking question for you. A 45-year-old male patient was seen in a local clinic and recently diagnosed with hypothyroidism, and he has been prescribed levothyroxine. As the nurse that's responsible for patient teaching, what are some key points to include for the patient? I'll give you a second to gather your thoughts. Because foods and other medications can interfere with the absorption of levothyroxine, it should be taken on an empty stomach. The patient should be told about this. Also, that the medication should be taken at the same time every morning. Patients need to understand that this medication has to be taken for the rest of their lives and that they should never stop taking this medication abruptly. Patients should also watch for any adverse reactions or effects and contact the prescribing healthcare provider if they experience any unusual bleeding or bruising, chest pain, palpitations, sweating, nervousness, or shortness of breath. The patient should also be taught to watch for the signs and symptoms of myxedema coma. Myxedema coma is when you have critically low levels of thyroid hormone. So we see really um, seriously low um, uh, thyroid hormone, and therefore all of those hypothyroid, um, low blood pressure, low heart rate in the extreme, low temperature in the extreme, um, and then hyperthyroidism as well. Okay, that is the end of the chapter 36 PowerPoint. If you have any additional questions for me about the chapter 36 PowerPoint, please don't hesitate to reach out and I'd be happy to clarify anything.